Good evening, sir. My topic for
Okay.
today is pre-operative evaluation and anesthetic management of a 4-year-old child with perforating eye injury for repair under GA. The traumatic eye injuries are common in children. After penetrating injury, the pressure in the eye will become nearer to the atmospheric pressure. So, any external pressure or increase in internal pressure will lead to the prolapse of the lens, iris, and vitreous, which decreases the chance of recovery of the vision. Um, so our main goal in the preoperative and in the operative room strategy will be to prevent the coughing, crying, and vomiting of the child, as these can increase the intraocular venous blood volume, and in turn, which increases the intraocular pressure, which leads to the extrusion of ocular contents. Now, we'll see the maneuvers which increases the intraocular pressure and which also decreases the intraocular pressure. Uh, which increases the intraocular pressure are Rayleigh tube insertion, oxygen face mask placement, laryngoscopy, intubation, bucking, coughing, increase in arterial or venous pressure, hypoxia and hypercarbia, which causes vasodilation and increases the intraocular pressure, and drugs such as succinylcholine and ketamine. Uh, the factors which decreases the intraocular pressure are head-up tilt because it decreases the venous pressure, decrease in arterial pressure, systolic BP of less than 90 mmHg, hypocarbia, all induction agents except ketamine, all non-depolarizing muscle relaxants, inhalational agents, and drugs such as acetazolamide and mannitol. So pre-operatively, our goal is to decrease the intraocular pressure, which in a child, it is quite difficult and challenging to accomplish. The child should be remain flat and quiet. The eyes should be patched to minimize the eye movements. But the eye patching itself can be quite scary and confusing to the young children. So we should sedate the child before patching the eye. Sedation can be with oral midazolam 0.5 to 0.75 milligram per kg or oral diazepam 0.25 milligram per kg. In children, most of the open globe injuries are associated with head injuries. So it is better to avoid narcotics when associated with head injury, because over sedation itself can increase the PaCO2, which increases the intracranial pressure, which in turn results in herniation and ultimately death. Um, Intranasal midazolam should be avoided in open globe injury because it can cause agitation and crying, which in turn increases the intraocular pressure. Another sedative option is alpha-2 agonist, that is dexmedetomidine. It is effective intranasal. It can also be given as an intranasal effective pre-medication. As an infusion dose is 0.2 to 1 mics per kg per hour, or loading dose 0.2 to 1 mics per kg over 10 to 20 minutes. Next is application of MLA cream because for IV access. Because IV access itself can stimulate crying and coughing, and which in turn increases the intraocular pressure in the children. So application of MLA cream, it provides adequate topical anesthesia. MLA is eutactic mixture of local anesthetic, which contains lignocaine and prilocaine of 2.5% each. It should be applied 45 to 60 minutes before the insertion of the IV cannula, or gentle induction of anesthesia by face mask with good pre-oxygenation with 7 to 8% sevoflurane can be done. Next, adequate analgesia and antiemetics should be given preoperatively. Analgesics is paracetamol per oral or per rectal 15 to 20 milligram per kg, or diclofenac per oral or per rectal at 1 milligram per kg, and antiemetics is ondansetron 0.15 milligram per kg, maximum of 4 milligram, or dexamethasone 0.1 milligram per kg. Taking the child to the operating room, consider the child as always a full stomach, especially after a traumatic eye injury, because after trauma, the gastric emptying becomes erratic. Pre-oxygenate the patient, but we have to take care to not to exert pressure on the eye. Our aim during induction will be to minimize the effects of the laryngoscopy and tracheal intubation. So this can be done by intravenous lidocaine 1.5 milligram per kg or remifentanil 0.7 mics per kg 3 to 5 minutes before induction, followed by propofol 2 milligram per kg or thiopentone 4 to 6 milligram per kg. Since we are consider the child, we'll proceed with RSI. With either succinylcholine 2 milligram per kg or rocuronium 1 to 1.2 milligram per kg to facilitate rapid sequence intubation. Among these, rocuronium has been considered to be safe for penetrating eye injury. Or beta blockers such as labetalol 0.05 milligram per kg. 0.05 to zero point 0.1 milligram per kg or esmolol 0.5 milligram per kg can be used because it blocks the cardiovascular response to laryngoscopy. This should be used only in conditions where beta blockers are not contraindicated. Intraoperatively, the adequate depth of anesthesia is should be maintained, and nitrous oxide is avoided because it increases the risk of postoperative nausea and vomiting. In extubation, airway protective reflexes should be returned, and the child should start spontaneously breathing, and the child can be extubated. During extubation, our aim is again to avoid coughing or bucking, which can be prevented by giving lidocaine 1.5 milligram per kg or remifentanil 0.5 mics per kg 5 minutes before awakening. And post-operatively, the post-operative nausea, vomiting, and the pain should be kept minimum. Thank you, sir.
There are a few points missing here, otherwise very good presentation.
Yes.
One is whenever a case scenario like this is given as a question, you look at the age of the child, patient. Here it is clearly given it is a 4-year-old child with a penetrating injury of the eye. Your anesthetic management. So here 4-year-old child means under what category of anesthesia it comes? Pediatric anesthesia or adult anesthesia?
Pediatrics.
So you have all the challenges of pediatric anesthesia.
Okay.
And 4-year-old child, will it have separation anxiety or not?
Yes, sir.
And then on top of it, the child also has an injury.
Yes, sir.
So child will be always crying and it will require the comfort of the mother or the parent to pacify the child. So that is a very important challenge. And we have used penetrating injury and open globe injury as though both are synonymous. Are they both same? At one
No,
point you
sir.
said open globe injury, another point you have said penetration injury. Penetrating injury is more an emergent one. Open globe injury, they can wait for adequate starvation or emptying of the stomach. Whereas in penetrating injury, what is the problem in penetrating? Why it should be attended earlier compared to open globe injury?
Because any vomiting or coughing will increase the intraocular pressure and there'll be extrusion of the contents.
See, supposing a pencil or a sharp object has penetrated, will somebody pull it out and bring the child, or will they bring it out with the foreign body in situ?
With the foreign body.
Then where is the question of contents spilling out? If there is a block by the foreign body in the eye. You understand my point? So that will not happen. Whereas the foreign body can produce endophthalmitis and infection. So you must remove that foreign body as quickly as possible under anesthesia and proceed with the correction. Okay, so that is the second challenge. So it is penetrating injuries compared to open globe injuries are always more emergently treated by the ophthalmologist. They don't want to wait. On the contrary, open globe injuries, many ophthalmologists will say Sir, if you say the child has eaten now and we have to wait for 6 hours, 8 hours, we will just patch the eye and keep it, give an antibiotic and take up later also. So that will be the adjustment by the ophthalmic surgeon. So you don't have to worry about open globe injuries where you can starve the child, give adequate fasting time, and then take up the patient. So the risk of emergent rapid sequence induction is not there. Third thing is, whenever the globe is being handled, either for a penetrating injury, we have not mentioned anything about the oculocardiac reflexes, which can be happening because of the traction on the eyeball more
Yeah.
than the it's something like handling a squint or a strabismus procedure. It is extraocular mostly. Okay, so that is the third point that we have to say. Problem specific to ophthalmic surgeries. And last point is this any ophthalmic surgery in children are more prone for nausea and vomiting. So you must
Yes.
take all measures to take care of that. So in this cases of questions of case scenarios, you always first enumerate the challenges that you face. Here I will say the first challenge is it's a pediatric anesthesia. Sorry, with a 4-year-old child who have a separation anxiety problem, managing that. All the differences between adult and the pediatric airway, the physiology, everything is different. I don't want to go into elaborate expansion of all that. You can just mention all the challenges of pediatric anesthesia is there, all the challenges of emergency nature of surgery is there, all the challenges of ophthalmic surgery like traction on the globe, oculocardiac reflex is there, and all the challenges of nausea and vomiting and pain is there. So these are the 4 challenges that you have to face, and accordingly, how you are going to use. Before that, how are you going to evaluate the child and then go and proceed with the anesthesia. Is there any role for blocks, regional, like peribulbar block? Because most of the ophthalmic procedures can be done under peribulbar block or subtenon block. Is there a role for that in this case?
Uh, no, sir. In
No.
pediatric and emergency.
Ah, not only that, any penetrating injury, to give additional volume into the orbital cavity, that is going to increase the intraocular pressure from outside. So regional techniques are not suitable for this procedure. So it has to be compulsorily a GA only. Okay. So if GA, you have to mention, give a little more points about what type of airway management. Are you going to intubate and keep an endotracheal tube, or are you going to use an LMA so that you cannot, you don't have to stimulate the airway, and while recovery it will not cause any coughing or straining and ducking and all those things can be avoided. So that discussion also has to be included. Okay.
Okay.
So I'll just show you how